Hi, this is Dr. Aaron Kowaleski at ECCO Medical. I'm here to talk to you about pelvic congestion syndrome. If you're watching this video, you may have increasing pelvic pain with longer periods of standing. You may have pain with intercourse or pain shortly after intercourse. You may have increasing pelvic pain with your cycle, and all of these symptoms may be made better by lying flat or even elevating your legs. If you have pelvic congestion syndrome, you would be a female. This is a condition that's pretty much exclusive to women, and for the most part, it's exclusive to women that have had at least one pregnancy. The incidence or the likelihood of having pelvic congestion syndrome increases with the number of pregnancies, but people can get it after just one. Some women can get it without having ever been pregnant, but that could be due to something called an impingement syndrome, meaning they may have something like May-Thurner syndrome or Nutcracker syndrome, where a vein is pinched in between two anatomic structures. Pelvic congestion syndrome is essentially varicose veins in the pelvis. So how do you get varicose veins in the pelvis in the first place? If you think about it, if something is caused by numerous pregnancies, as that uterus gets big, it can damage the veins in the pelvis just by the sheer weight of the uterus on those veins. So they can become incompetent or stop being able to actually work and push blood back up to the heart. In this case, there is one vein in particular that feeds all of these varicose veins in the pelvis on the left side. It's called the left ovarian vein. That left ovarian vein actually comes upwards, plugs into the left kidney vein, and then goes over to the inferior vena cava, which is essentially the aortic equivalent of the veins, and then goes back up to the heart. It occurs less frequently on the right because the right side has a straight shot up to the heart, essentially through the IVC. It doesn't have that turn that I described that the left side has. How does this cause pain? So varicose veins in your legs or in your pelvis are just veins that are unable to push blood up to your heart anymore, especially when you're standing upright, because gravity plays a role pushing that blood back down. So over time, if you're standing, that blood stays in the pelvis and it causes those veins to stretch. And so the pain in your pelvis is from constant stretching of those veins with blood. And that's why it gets worse throughout the day and with longer periods of standing, because more and more blood pools. That can also cause inflammation. Sometimes you can even get clotting of those veins, which can also be very painful. During your cycle, the pain can also be worse because your uterus and your ovaries are demanding more blood during ovulation, so therefore you have more blood coming to your pelvis as well. Pelvic congestion syndrome is also regularly associated with May-Thurner syndrome. And the way this can work, and this is one of the ways that women that have never been pregnant can get pelvic congestion syndrome. When you have that narrowing in the left side of your pelvis and that vein in the left side of your pelvis, that blood needs to get back to your heart somehow. So it will try to find collateral pathways to get back to your heart. One of the things it can do is find a collateral pathway into the left ovarian vein. And then all the blood from the leg is trying to get back to the heart through a tiny little ovarian vein. Over time, that vein will dilate, stretch, and become damaged due to the increased volume. And therefore it creates this large incompetent vein that leads down into the veins around the ovary, the left ovary, and the uterus, thereby creating those varicose veins due to that impingement of the left iliac vein. How do we diagnose pelvic congestion syndrome? Well, first and foremost, there is clinical visit where we just go over symptoms. And from there, we order imaging. That's usually going to be a CT scan or an MRI. They have CTs and MRIs that are specialized to look at the venous structures. From there, we are able to get our diagnosis and discuss those with you so that way we can come up with a treatment plan. What are the treatment options for pelvic congestion syndrome? Essentially, there are two, although there's really only one. The surgical option, where they go in and tie off the veins, has fallen out of favor because the less invasive options have seen increasing success rates and are actually more successful now than the surgical options. So they don't really do the surgeries anymore, and pretty much everyone is sending patients for the minimally invasive procedure, which is called a venogram. As far as that procedure goes, we do those here at ECCO Medical. They're outpatient. You walk in, you walk out. Procedure takes about 45 minutes to an hour. We use moderate sedation, which is not general anesthesia, but you are asleep for the procedure and don't really remember any of it. The way we do the procedure involves a single needle stick. The access site or the vein that we go into really depends on what we see on the CT scan or the MRI, which gives us a better idea of the anatomy that we're working with. So the two veins that we'll use is either going to be the one above the collarbone, the internal jugular vein, No incision, just a single needle stick, or we'll go through the left common femoral vein in your left groin. We get into the vein using ultrasound guidance. We numb up the skin. We advance a needle through the skin into the vein. That needle is hollow. So then we're able to thread a wire through the needle into the vein. And that wire we can see on x-ray. So we can guide that wire through the veins into the incompetent vein. In this case, it's typically the left ovarian vein. We are able to get the wire into that vein. Over that, we're able to thread a little tiny tube or catheter. And then through that, we're able to put a plug into the incompetent vein called a coil. Coil is usually a long piece of platinum, which has some fibers on the outside to induce clotting and shut down that vein itself. The ones that we're using are going to be 1 to 2 millimeters in diameter, so pretty small. It doesn't move. Any clot that forms on it doesn't move either. There have been studies to show that it does stay in its place. That plug that shuts down the incompetent vein forces the blood to reroute away from that pathway into veins that work. So that way the blood can return to the heart, restoring normal flow out of the pelvis, decreasing your symptoms and decreasing your pain. Sometimes, depending on the amount of varicose veins in the pelvis or the anatomy, we have to do what's called staging, meaning that we'll do one procedure to get the majority of the veins treated, but then we would bring you back usually about 30 to 45 days later to do an additional procedure to go and clean up or treat any remaining veins that we were unable to get at the first procedure. For the most part, depending on what we do in the procedure, you really don't need any post-procedure medications other than over-the-counter anti-inflammatory medications. There isn't a significant amount of pain after this procedure if it's just treating that vein. However, if you do have May-Thurner, which can cause pelvic congestion syndrome, and we do place a stent, then you would need to be on blood thinners for a month. We have routine follow-up at 1 month, 3 months, 6 months, and 12 months after the procedure, just to see how things are going and to make certain that you're recovering and progressing as we would like. Success rates for pelvic congestion syndrome treatment involving embolization or plugging of the vein approaches 88% relief of symptoms, meaning that 88% of patients saw complete relief of symptoms at 1 year. Complication rates are very low, around 1%, and it usually involves the access site, meaning where the needle goes in and which vein it goes into. That usually involves some bruising. Veins don't hemorrhage or have major bleeding complications like arteries can, so that's not an issue that we have to worry about. There's always a risk of infection at the skin site, no matter what we do, so we always provide an antibiotic on the day of the procedure to decrease that risk. One of the things that's important to understand about pelvic congestion syndrome is that there is a recurrence rate of about 10%, meaning that 1 in 10 patients that get this procedure done do have symptoms come back. That recurrence rate can go up if there is an additional pregnancy after the treatment. As you can imagine, it's the same concept of the uterus, the enlarged uterus, compressing those pelvic veins and really starting that whole process all over again. Typically, if we're going to treat pelvic congestion syndrome, we usually ask patients if they're done having children, and we recommend just doing one treatment if you can. In some cases, some patients have such severe symptoms in between their pregnancies that they opt to get the treatment done regardless and figure that, hey, if the symptoms do come back, I can always get the treatment again after my last pregnancy. The minimally invasive procedures we do at ECCO Medical are outpatient. You walk in, you walk out, and they're very low impact on your body. We use moderate sedation for the procedure, so you're snoozing or completely asleep throughout the procedure, but we're not putting a tube down into your lungs to breathe for you like you need to do with general anesthesia. In general, people don't remember the procedure. They may remember a flash here and there, but for the most part, you don't remember anything about it. It's safe. We do it here every single day, and we have skilled and trained staff to be able to administer these medications safely. One of the things that's near and dear to my heart and very important as far as pelvic congestion syndrome and really just chronic pelvic pain in general. Chronic pelvic pain is a diagnosis given to a lot of women when other people like primary care physicians and OBGYNs really don't know what's causing their pelvic pain. Chronic pelvic pain, or CPP, accounts for about 12% of hysterectomies, meaning that the docs don't know exactly why they have pain, so they just go in and do a major surgery hoping it works. And it doesn't. About 33% of those patients have no pain relief after a hysterectomy, so they had a huge surgery to really get no result. About 20% of exploratory laparoscopies, or it just means that the doctors don't know what's going on, and so they do a surgery with the camera and they go and they look around. 20% of laparoscopies are just due to chronic pelvic pain with no cause. The reason for this is that a lot of OBGYNs and primary care docs, it's not their fault. They're just not trained to look at or consider vascular issues. And that's where we come in. And so a lot of chronic pelvic pain is caused by pelvic congestion syndrome, which is a vascular issue that if they don't treat it, they don't know to look for it. So it's very important if you or loved ones or friends have similar issues to you, because that's why you're watching this video, please encourage them to go to see a vascular specialist like an interventional radiologist, so that way we can avoid any unnecessary surgeries or any high-risk things that other people would do. If you have any questions that weren't answered while you were watching this video, or if you think of anything afterwards, please don't hesitate to ask me or one of the providers that you speak with. We're always going to be available, and you can always call us if you forget to ask us something during your consultation.